I'm not sure. Do you want to wait for Dr. Thapa? I'm not sure if Dr. Thapa will be joining. Right. She did not respond to the email, right?
Yeah, but Say is online. I don't know.
Say is online?
Yeah.
So she's joining?
Yeah, she said, she emailed me, she had some problem with the link. But
Okay.
she figured that out, so she will join, but I don't know.
Okay. Okay. So maybe we can give her a couple more minutes. So.
Yeah. Oh,
Okay.
she's online.
Hi, Sam.
Hi. Hi, Adam. How are you?
Good, good.
I say.
Hi, John.
Well, maybe we can get started. See, I don't have the program. I think my presentation is the last one, right? I think either Hee-Jung or Say, do you want to start or?
Oh, I can start.
Okay.
Oh, we can start now. Okay, I will start first. So our paper is about social determinants of cardiovascular health, and also it's a longitudinal analysis of cardiovascular disease mortality in US counties from 2009 to 2018. Oops. So racial and regional disparities in cardiovascular disease outcomes persist across the United States. In 2017, about 12% of non-Hispanic white adults, 10% of non-Hispanic Black adults, and 7% of Hispanic adults, and 6% of non-Hispanic Asian adults had heart disease. For CVD mortality, non-Hispanic Black adults were more than twice compared to non-Hispanic Asian and Pacific Islander adults. And rural residents experienced a higher CVD death rates than urban residents. Social determinants of health plays an important role in driving racial and regional disparities. The leading disparities by SDOH include a complex interplay of multiple domains at various levels, including socioeconomic status, structural racism, and neighborhood environment, healthcare systems, and also social needs such as food insecurity, housing instability, lack of public transportation, and poverty. The purpose of this study is to identify key social determinants that are associated with cardiovascular disease mortality in the United States counties. So we specify the data sources in method section. We use the data from the 2009 to 2018 SDOH database from the Agency for Healthcare Research and Quality. The SDOH data were collected from existing federal data sets, such as American Community Surveys, Area Health Resource Files, Environmental Protection Agency, and American Hospital Association for multiple years. And also community level SDOH variables in AHRQ's database span 5 domains and 30 topics. In social context, it has demographics, disability, immigration, living conditions, segregation, and socio-economic disadvantage indices. And economic context domain has employment, income, and poverty. Education domain includes attainment, education funding, literacy, numeracy, and school system. In physical infrastructure domain, it has crime, environmental, food access, housing, industry, composition, internet connectivity, and migration, and social services, also like transportation. And last, the healthcare context domain has characteristics of healthcare facilities and characteristics of healthcare providers, health providers, and healthcare quality, health insurance status, health outcomes, and utilization and cost. And also framework for SDOH has like these 4 like framework, like structural determinants of health, social determinants of health for individuals, and then assess use and quality of health services for individuals, then health and well-being of individuals. Another data source is from the CDC Interactive Atlas of Heart Disease and Stroke on provided county level heart disease and stroke data by race, gender, and age group. Mortality data were from the National Vital Statistics System provided by the National Center for Health Statistics. The age standardized CVD mortality rate was measured as the number of deaths per 100,000 persons, and cause of death was defined using the International Classification of Diseases. The AAHRQ's SDOH data were linked with CVD mortality data at county level from 2009 through 2018. In the SDOH variables, the analytic sample included 3,142 counties and 1,166 were classified as urban counties and 1,976 were rural counties. SDOH data contained 345 variables, but we included 78 variables that were measured over 10 years and excluding those with large missing values like over 60%, and also variables that have the same or similar definition were dropped. For statistical analysis, so panelized generalized estimating equations for simultaneous variable selection approach were applied to select the key SDOHs that were associated with county level CVD mortality. A complete data set was implemented with PG in our package, then generalized estimating equation were used to fit the linear regression model for CVD mortality. And then multi-collinearity was tested among selected variables from the PG analysis, and the final model included 17 variables. The PG was proposed by Wang et al. In 2012 to analyze the longitudinal data with high dimensional covariates, because it may be practical to assume that a large number of covariates in the high dimensional covariates are not valid from modeling the marginal mean of study outcome. So in the results part, we visualize the changes in CVD mortality rate, and these maps were associated with geographic and racial disparity at the county level between 2009 and 2018 by the mapping. The overall median CVD mortality rate was used as a bivariate threshold, and in the second map, 30% cutoff value was used to define the racial composition of each county, measured by the percent of Black residents. In 2018, the number of counties with a higher CVD mortality was smaller than those in 2009 in both rural and urban counties. And in both maps, slight decline was observed in the south and northeast of the US, and also in west, the CVD mortality decreased among a number of counties in California and Nevada. And also in Alaska and eastern north central states of the Midwest region, a reduction in CVD mortality was observed. And next, trends in counties with 30% or more Black residents versus counties with less than 30% Black residents were plotted to visualize the change in CVD mortality over 10 years. Overall, a downward trend in CVD mortality across counties was observed in the past decade, but the CVD mortality was persistently higher in rural counties than urban counties, and also in counties with more than 3% of Black residents than in counties with lower than 30% of Black residents. Since the trend line are parallel, it may be no significant change in CVD mortality gaps between rural-urban counties and counties with a high versus low percentage of Black residents over the past decade. And so next, table 1 describes the selected SCOH variables associated with CVD mortality from the penalized generalized estimating equations. It's kind of long, but we need to mention everything because they are like key social determinants of health. So within the social context domain, selected variables include the percent of families.
Hello, I'm excited to invite you to participate in the 2022 AAEA annual meeting taking place July 31st through August 2nd in beautiful Anaheim, California. It will be taking place at the Anaheim Marriott.
I'm sorry, what happened?
We will have.
Can I keep going?
Yeah,
Yeah.
feel free to, because
Okay.
someone probably forgot.
Sorry. We have your name. Please continue.
So in table 1, the table 1 describes the selected SCOH variables associated with CVD mortality from the PG estimating equations. So within the social context domain, selected variables.
Oh.
Hee-jung, you muted yourself.
I'm sorry, so many troubles here. Yeah, anyway, this table includes key STOH selected variables. So I tried to go through like one by one, but I think we will skip this part. Next table. So we fitted G adjusting for the county level selected STOH variables with the findings, and it is shown in table 2 actually. Yeah. So based on our study aim, I will just briefly talk about the results here. And CVD mortality has been declining for the past decade. The CVD mortality remained higher in rural counties compared to urban counties. The percent of Black residents was positively associated with CVD mortality, and other significant variables can be explained like similarly. And then after selecting the important STOH indicators, we included all the possible interaction terms to account for potential association between the variables. This table shows the GE model that included interactions with rural urban status and racial composition of county. The changes in CVD mortality between rural and urban counties were not significantly different. By the trend graph, we assumed this result before. The change in counties with high percentage of Black residents was significantly decreased over time. And also CVD mortality decreased in counties with higher median household income. But these protective effects seem to be larger in rural compared to urban counties. But the percent of households who receive food stamps among those married partner households had different results from the median household income variable. So last section is discussion, and the CVD mortality rate declined in the US over the 10-year study period, with a faster decline in counties with higher percent of Black residents. And rural counties continue to experience a higher CVD mortality, and changes in the rural-urban CVD mortality gap were not statistically significant over the past decade. And other STOH indicators such as education, housing, insurance, and transportation were consistently associated with county level CVD mortality. So this study can help us move beyond the documenting disparities toward identifying pathway for improving health equity across the life course, and also continue to explore use of STOH data at the point of care. And also it can help us provide important contextual data that can be included in all clinical research studies, and understand the role of community and structural factors in disease onset, progression, and outcomes. Yep. Thank you.
Or muted, no, not. Oh, no, sorry.
Yeah, it's
Do you have any questions for Hee-jung? Any questions outside in Los Angeles? Hee-jung is a PhD
I do
student.
have a question. If you can hear me though, can you hear me?
Oh yeah.
Oh, okay, good. So I was just wondering if you had a chance to examine occupation as well. Because a lot of these disparities sometimes are related, obviously to certain jobs, certain occupations, and I don't know if you looked at that.
I'm sorry, I don't really understand because the sound is echoing.
Okay. I'm gonna get a little
Sorry.
closer. That might go over here? Yeah, I think that's. Oh, yeah, so sorry about that. I am totally, can you hear me better now?
Yeah, a little bit better.
Okay, I was just wondering if you considered occupations, like looking into, so you looked at a lot of demographics.
Hello?
Graphic factors, but if
I think
occupations.
the professor was asking if you have considered occupation, what occupation of which the patients. But Hisha, my understanding is that you are using the county level data, right? There's
Yeah.
no occupation available.
No occupation, yeah.
Thank you.
Sorry,
That's okay.
really.
That's all right.
Any other questions? Sorry, I am picking up the the sharing rule. Yeah, Dia, do you have any questions, Dr. Pham?
Hi, sorry I'm joining late. I don't have question on this one, but good presentation. Thank you.
Thanks, Dee. Well, if you're not, maybe we can go to the next presentation. So you can use a long time. My presentation is going to be short.
Should I go?
Lisa, I think you probably have to exit the
Oh.
sharing.
Sorry.
Oh, okay. I'll just go. Let me see.
So this session actually is a UGS session. So it's a postdoctoral research with the Department of Health Policy and Management, UGA. And Hee-jung is a doctoral student with the Department of Epidemiology and Biostatistics.
Can you see my PowerPoint?
Yes, we can. Yeah.
Okay. So our study is urban differences in utilizing service among adult patients aged 18 to 65 diagnosed with obesity. And for this, we use the market commercial claims data set. So obesity, it's a public health problem, and in 2017 to 2018, the prevalence of obesity among adults was 42% in United States. And as we all know, obesity increases the risk of other diseases such as stroke, heart disease, lung cancer, diabetes, and it has also been found to be associated with well-being. And individuals with obesity, studies show that they experience decrease in life expectancy, and it also has like impact on individuals' health-related quality of life and their work productivity. And obesity also brings substantial financial burden in the United States. And so in 2016, the national medical cost due to adults' obesity in US was over 260 billion. And obesity is a public health problem nationally, but among US adults, it's also evident that socio-demographic and geographic regional disparities in obesity still exist. And studies further show that there are rural and urban disparities in obesity. And across the studies, the prevalence of obesity was higher among adults living in rural areas compared to adults in urban areas. And studies show that rural adults were more likely to be physically inactive compared to urban adults. And they have lower fruit and vegetable consumption, and they also have like higher daily energy intake and consumption from fat among rural adults compared to urban adults. And specifically in terms of burden of obesity among adult population in rural area, some of the factors that contribute to such burden, it includes like income inequality, perception of towards obesity, health policy and access towards obesity, and social factors. There's also challenges related to implementing obesity-related prevention services due to there's like a lack of service and workforce and specialized services in rural areas. And so, as I said, there's a shortage of healthcare workforce in rural areas. So rural areas, they face shortage of healthcare workforce, and healthcare facilities in rural areas compared to urban are less likely to have nutritionists, dietitians, or weight management experts available. And furthermore, like study found a preventive counseling was more common in urban practices, and it was less in rural in United States. And so among adult patients, percentages of their visit to urban practices, including diet counseling and exercise counseling, were much higher compared to rural practices. And so these emphasizes the need for better provision of obesity-related preventive and counseling services for adults in rural areas. And they show that weight loss counseling, it helps overweight and obese patients to lose weight. And actually in November 2011, the Centers for Medicare and Medicaid Services, they determined to cover intensive behavioral therapy for eligible Medicare beneficiaries with obesity. So in terms of behavioral therapy, it includes intensive behavioral counseling and behavioral therapy to promote sustained weight loss through high intensity interventions on their diet and exercise. And so studies supporting such as counseling helps weight reduction among obese patients, but then uptake of counseling is still low. A study shows a decrease in obesity-related counseling from 1995 to 2004. So compared to 1995, odds of receiving any type of obesity-related counseling was 18% lower during 2003 to 2004 years, and low rates of counseling types for the obese patient visit informs that obesity is often undertreated. And other challenging in terms of engaging patients into counseling might be that many primary care providers, they do not offer or perform weight-related counseling during obese patients' visits. And some other challenges to obesity counseling in primary care settings include a lack of primary care provider training, provider weight bias, lack of reimbursement, lack of time during encounters, and providers their limited ability to refer patients to weight management programs. And some studies show there's some possibility of like dropout reasons from receiving obesity treatments, which also includes the patients having full-time employment. Study found that patients who dropped off from obesity treatment were more likely to work full-time, and they had a conflict with our objective for this study was to examine differences in uptake and utilization of obesity-related counseling by rural and urban. So for we used 3 years of market scan, commercial, and encounters data sets. And obesity was defined by using ICD-10 E66 code. And in this study, the primary outcome was obesity counseling, which includes 5 different categories: prevention, nutrition, disease management, behavior consult and therapy, and face-to-face behavior counseling. Those were identified using CPT or HCPCS code. And for our study, counseling rates were computed as proportion of number of patients that received counseling to the number of patients diagnosed with obesity. So for our covariates, we included age, gender, rural, urban, census region, Charleston Comorbidity Index, health insurance plan, and employment status. So this page shows categories of 5 different obesity-related counseling and treatment included in our study. And long list, I will just skip this part. So to generate our study cohort, we first identified patients diagnosed with obesity using ICD-10 code, and they were longitudinally tracked if patients received any type of counseling for obesity. And second, patients, they had to be continuously enrolled for the 3 years of our study period. And we used 12 months washout period from January 1st, 2017 to December 31st to make sure that there was no prior diagnosis with obesity. And we used 6 months of observation period after the diagnosis of obesity from January 1st to June 30th, 2019. And so this total number of patients, 981,000. But then for our adults population, we only included those 18 to 65 years old patients, which led to final sample size of 935,000. So among our total obesity diagnosed adult sample, only 3.52% utilized one of the obesity counseling services in our study. And this is our descriptive. Our descriptive statistics show that 30% of our sample are female. They live in urban areas. They live in South region, have out of network, and majority of them have active full-time employment status. And so majority of our sample indicated utilizing prevention counseling. And then 38% utilized nutrition, followed by face-to-face behavior consult and therapy. And the last one, only 1% utilized disease management. And this page shows characteristics of our sample by different counseling types. So similarly, similar to previous descriptive, across all counseling types, there are more female patients, and majority of them live in urban and South area. But then across all counseling types, the distribution of health benefit plans are a little bit different. And majority of patients, they do not have any comorbidities, and more than 30% of those utilizing nutrition or disease management, they have 1 to 2 comorbidity conditions. And across all counseling types, majority of patients have full-time, and slightly more retiree patients compared to part-time. They utilize counseling services except for behavior consult and therapy service. For this, we ran logistic regression. So our results shows that there is a significant association between being older age and utilization. So compared to 18 to 29 years old, 30 to 49 years old are more likely to utilize any of the counseling services. And compared to male, female are more likely to utilize counseling service. And our focus is the rural and urban areas, and utilization of counseling in rural areas is much lower compared to urban. And compared to those without any comorbidities, those with some comorbidities are more likely to utilize the service. And there is an increase also of utilization among patients with high deductible and primary care health insurance. And there's also increased also of utilization among patients with full-time and part-time but there's a decreased odds of utilization among retirees. So we first ran the regression model for the full sample and then followed it by running the model separately for each rural and urban and region combinations. So this allowed us to examine and compare marginal probability in rural and urban areas by US regions. And as you can see, the results show that compared to urban areas, patients living in the rural areas of across all regions, they are much less likely to utilize the obesity counseling services. So our conclusion. So during our study period, only 3.52% patients with obesity received counseling. Among them, 40% received prevention, followed by nutrition. And patients living in rural areas, they were less likely to uptake obesity counseling compared to patients in and our results show that being female and having comorbidities were positively associated with higher level of obesity counseling uptake compared to male and patients without any comorbidities. And for the region, living in North Central, South, or West region, having comprehensive and primary care plans and being retired were negatively associated with receiving obesity counseling compared to patients living in Northeast and having basic medical plan and working full-time. And so in conclusion, I guess our primary results show that just few patients with obesity receive counseling. Also, patients with obesity living in rural areas were less likely to utilize the obesity counseling service. Our study emphasized the importance of encouraging obese patients to receive counseling and also the physicians to offer counseling. And so some studies show that some states do cover counseling for obesity, but not all the states cover obesity counseling as a preventive services. And depends on the plan, patients can be covered by obesity counseling and or not. And have some of the limitations. So our study time frame is 2017 to 2019 due to our data availability. So our descriptive results may have been different if we were to use the most current years of data sets. And we may have underestimated obesity-related counseling uptake rates, and results may be skewed due to our method of data collection for obesity counseling received by adult patients. The codes that we use for counseling may not be frequently or commonly used by primary care offices, and so it might affect our counseling uptake rate. In market scan commercial data, it only covers patients insured by private insurance plans, so it cannot be generalized to people who are covered under Medicare or Medicaid. So this is the end of the presentation. Sorry if I went by so fast.
Great presentation. Yeah, very nice study. Yeah. Any questions?
Yeah, I actually have two questions. The first one is, do you control for access to services in urban versus rural areas? For example, if you live in an urban area, there might be more available services, whereas in rural areas, the service is limited. So it's not a matter of taking counseling, it's a matter of availability and access.
Availability and access.
Right.
I don't know if those measures are available in the market scan data set. But
yeah, I guess that's a good. The business establishment data set, I forgot the name of it. So, like, if there's a clinic or there's a service, you might be able to look up those information.
thank you.
Yeah, and my second question is: do you control for the obesity rates for that specific region? So I see you have different regions.
Mhm.
And it could be if I live in a particular region that has high obesity rates, and I am, for example, has low obesity rates, and I am obese, then I feel out of place. Then I feel more, there's more stigma towards me being obese. You know, it's more like, do you fit into the norm of the region? Would that maybe play a role into, you know, me seeking obesity counseling or not?
Yeah, we didn't really control for like regional that like norm, or yeah, but I think that's a good point too. Yeah, but we didn't have like available measure for like regional specific norm for like obesity, but yeah, I think that's a good point.
Right. Yeah, I think that's a very good point. Yeah. Although monkey scan, you do not have the geographic identifiers except in census region. Yeah, you won't be able to access the county. I think you were trying to say the county business pattern, right? That I said. Yeah, no, you monkey scan before 2010. Actually, you can have I think either zip code or county identifier, and you can match that. But after 2010, you won't be able to connect to a county level or a zip code. Though, say, I think maybe you can explore the MSA code. I think you may be able to match with the MSA code and see if there might be any difference that you can control for that. Although I think a county business pattern, it might be, I'm not sure if they have a MSA level equivalent. Yeah, that's something that you can look into. Yeah,
Okay.
but I think these are great ideas.
Yeah,
Yeah.
thank you.
Sorry,
Thank you so much.
Yeah, I do have a question for you. Actually, you were trying to generate new incidents of obesity. Why you were trying to do that?
Could you repeat again? Sorry.
You are trying to generate define new cases of obesity, right? You had a washout period of 1 year washout period. Yeah, those for cancer, for diabetes. I think that would be actually preferred. But for obesity, I was curious, what's the rationale? You did that, or why you did that?
Oh,
The 1 year washout.
because I think Dr. Tapa might have better answer for
Okay, I
that.
see.
But yeah,
Yeah.
we just
For obesity, it's a bit tricky. For cancer, well, you could still say, because cancer, you won't be able to, well, I'll put it this way. For cancer, if you have new case, you will go to see the doctor, and you will have a claim, right? Actually, defining a cancer using monkey scan is a bit tricky. As often we would need two claim codes of is specific cancer, just to rule out the screening. Sometimes if a woman performs a mammography, and they might have actually they will have a breast cancer code on their claims. Although does not mean that she's diagnosed with a breast cancer, but it means that the doctor is trying to see if she has breast cancer. So in some, most of the study will use if the person has a washout time period, and then within a time period, maybe 60 days or 30 days, they have two codes of breast cancer, then the person is defined as a breast cancer case. Yeah. But for obesity, it's a bit tricky, because obesity, well, even if someone is obese, but they do not have any symptoms, they will not visit the physician, right? They will not have claims. So they are obese, but they are not in the system. They're not in the in your market scan database. So even if in the washout time period you don't have anything, but because he or she had a flu and visited physician in the 2018, the second year, but well, the physician or nurse will weigh and measure the person, and you will get a ICD-10 code of obesity, but it does not mean that it's a new case, right? So I think you're trying to say a new case that actually is it's probably not new case, or maybe you can say it's new diagnosed case. But yeah, obesity is not condition that they're trying to diagnose. So it's tricky. It's probably maybe you know, something that you probably want to think about.
Yeah. Thank you, Joe. Thank you. Yeah. We'll think about that one.
Sounds
Thank you
good.
for the good point.
Well, I think it's just the four of us, right? Okay, good. Well, my presentation actually is very short. I have not finished the study I wanted to do, but let me share my screen. Maybe I can talk a bit. Okay, stop. Sorry. So let's talk a bit about this idea. So what do you see? You see, okay.
Yes, I can see.
Well, so the objective of this study is try to define, try to measure the disparities in genetic testing counseling. Sai has talked about obesity counseling. We are also trying to see if there's genetic counseling. Yep, and well, it's really simple. So this graph, I want to talk a little bit about it. So in 2001, when the scientists from the 6 countries, I think United States, UK, Japan, and France, Germany, and China, the 6 countries, and they mapped out the human genome. This was the first time they mapped the human genome, and it's cost, I think it's more than $100 million for mapping of the human genome, probably much more than that. So yeah, so that's 22 years ago. But over time, the cost of sequencing the human genome, it dropped really fast. Actually, even faster than the Moore's law, which is for the chips, right? So nowadays it's under $1,000, and sometimes when you I think during the Christmas, you might have a sales that you can get $99 to sequence your genome. I'm not sure. Are you guys a fan of 23andMe? Have you done 23andMe? The so. Yeah, the 23andMe self-testing kit actually costs sometimes I think $99, which you can sequence your genome, and find out your health condition, but with probably with additional cost, and well, not health condition. Well, they can identify some health conditions, and also any genetic traits. Sometimes they even have a hereditary lineage where your parents from, and they can see that. So the cost over human genome, sequencing human genome dropped really fast, dropped dramatically over time, right? Exponentially. Well, there's two consequences of that. Two consequences of the drop of cost. Number one is that, well, there's much more demand for genetic testing and counseling, right? To Sai and Hijang and Dia, have you guys done the 23andMe testing?
No, I have not. I'm afraid to see what I'm going to find out.
Okay. Yeah, maybe you can watch for the Christmas sale. 23andMe, sometimes they do have a 99 or 199, and it's send you a kit and you spit into the test tube and seal that and send back to 23andMe. And I think in 2 or 3 weeks they will send you the results. So, well, a lot of people do that, and in China, I think there's another company do that as well, WeGene. And well, given these technologies, given the really lower cost of the genome sequencing, a lot of people are doing that, right? There's an increased demand for genetic testing, for genetic sequencing and testing. And also genetic testing actually has a lot of applications for law enforcement. You probably have seen that a lot of cold cases were solved by genetic testing, right? There's a lot more demand. So, well, given this demand, there's a demand for interpretation of the results of genetic testing. You guys have not done the genetic, the 23andMe, but the 23andMe actually, they will provide you as raw results. They will not interpret the results because those results tends to be very tricky, tends to have a lot of information that only genetic counselor can understand and interpret what kind of risk you have. Keep in mind, FDA actually approved the over-the-counter genetic testing, I think several years ago. Yeah. And FDA actually had been very conservative in approving the genetic testing for the over-the-counter version of genetic testing. So that's number one. Well, we have increased demand. We have increased the demand of genetic testing, and we have increased the demand of genetic counseling, right? But the other trend is that given that there's a lot more work relates to genetic testing, we have an increasing, really growing market, and we have a lot of companies actually doing the genetic testing. So a lot of people with such expertise, clinical genetics, actually they were drawn to the industry. They were drawn to the biotech companies, right? Genentech and 23andMe, so these type of companies. So, well, the workforce that provide the genetic testing, genetic counseling, actually is well, it is increasing, but it's not meeting the demand of both the clinical interpretation of genetics, the genetic counseling, and the demand from the industry. And as of April 2021, they are only 5,629 certified genetic counselor in the United States. And I have not I don't think I have it in my slides, but the distribution of genetic counselors is very maldistributed. It's very unbalanced across the country. Yeah. California, New England area, they have a lot of per person, or in terms of per 100,000 population over genetic counselors, they have a much higher. I think it's about 10%, but for the others, it's much is much, much lower. Give you an example of the BRCA genetic testing. It's the testing the hereditary breast and ovarian cancer because of mutations in the BRCA1 and BRCA2 gene, which increase the cancer risk. By it's 45 increased by 45 to 65% risk of breast cancer by age 70 among women. And it's also increased the risk of 17 to 39% risk of ovarian cancer by age 70. And it also increased the risk of other cancers in men and women. It's indicated whether when personal or family history shows increased risk and informs interventions for cancer prevention and early detection, which is meaning that if someone tests for genetic testing, for BRCA genetic testing, and find out that she does have the BRCA1 or BRCA2 mutation, most likely her relative might have or more likely to have the mutation because it's often hereditary. It carries over from mom to daughters. So it is possible. And if a woman tests has the BRCA1 and BRCA2 mutation, it's often recommended that her relative, female relatives, should test that as well. It's called in genomics terms, it's called cascade testing. Well, genetic testing does have a lot of benefits, right? And what do we do once if someone has a mutation? What kind of interventions they can have? Well, they can have a risk-reducing medications, and they can have a surgical removal of breasts or ovaries. Yeah. If you guys follow the news, well, it's old news. Angelina Jolie, actually, she tested positive for BRCA1 and BRCA2 gene mutation, and actually she removed her breast tissues and also ovaries as well after giving birth to her babies. Right. So it's BRCA genetic testing does have a lot of important benefits, critical benefits, and BRCA1 actually for genetic testing also have a lot of policy implications or result from policy changes. Yeah, I probably can skip the previous one on different kinds of recommendations. Well, 2005, U.S. Preventive Service Task Force actually provided a recommendation that provided a recommendation that women should test for should have the genetic testing, but it's more general. It's not a specific testing, specific recommendation. And then NCCN, these professional societies actually recommended the genetic testing as well. And during 2007 to 2011, there's a lot of discussions about directed to consumer marketing, which is what Tunisia and MIA is doing, right? And in 2008, US actually passed the GINA, Genetic Information Non-Discrimination Act. And that law actually provides protection against the use of genetic information towards a patients. So employers cannot discriminate anyone because of a genetic information, and the insurance company actually also cannot discriminate someone because of genetic information. So GINA actually, well, insurance, the clause on insurance actually started in 2009. Well, so GINA provides a lot of incentives for people to have the genetic testing, because the consequences of genetic testing is much less than that. And in the past, if you tested something, you probably were worried about someone might discriminate you. But after GINA, employers, health insurance companies cannot discriminate. They are forbidden by law, but to discriminate anyone based on genetic information. And ACA in 2010, and ACA does have a clause on the preventive service, right? And in 2013, ACA clarified to provide a clarification on the preventive service, so that I think it's on the testing and also counseling over BRCA testing. And in 2013, it's about, I think it's May, Angelina Jolie's case. She published a op-ed in New York Times about her condition, about her decision to, well, about her test of BRCA genetic testing and her decision to remove surgical removal of breast and ovary. And then in 2013, another important decision, which is the Supreme Court decision to strike down the patent of BRCA test, the BRCA gene. And before 2013, the company Myriad Genetics actually had a patent on BRCA gene. It's interesting. They award a patent to a certain gene, right? But before that, so any company, if they test BRCA gene with any methods, they have to pay Myriad Genetics a royalty. Yeah, but after that, in 2013, the Supreme Court actually struck down that patent, considering that a patent on a gene, something in the nature, is not natural. It's not something that we should do. Right? So struck down that patent. So after that, the price of BRCA test dropped sharply. And we also have a U.S. Preventive Service Task Force recommendation in 2013 as well. So yeah, we also used the market scan as well. So this paper that we published in 2018, we tried to see the utilization rate and cost in the context of potentially influencing factors, which is we haven't just talked about. So having some issues. And well, we can use health claims data for assessing BRCA test utilization and costs. There are some minor points that we have to details that we have to deal with. There are billing codes for gene sequencing and large rearrangements, known mutations, and also the Ashkenazi Jewish panel. The market scan is really a large database, and we do have actual amounts paid by plans and also the residual amounts expected from patients. Age and the census region data available, and we have some medical history data available. And there's also specific billing codes for BRCA test evolved over time, and that they have the HCPCS code is something that they do before a formal CPT code is used, which is called specific billing codes. And specific billing codes is a set of HCPCS codes. And I think Sai probably really discussed about the pros and cons of market scans. So I probably can skip that. So this is the result of in this study, which we tested examined the BRCA testing among women by metro and non-metro. The reason we use this term is that in market scan, actually they used metropolitan or non-metropolitan, which well, it's loosely defined rural and urban. We can see that from 2009 to 2014, there's there's disparity between urban and rural, and there is actually an increase in the utilization of a BRCA test from 2012 to 2013, possibly because of the Angelina Jolie's promotion, right? Because the celebrity, she talked about the BRCA test, and this is consistent across the 4 gene sequencing and large rearrangement and also known mutations. And the reason we have this only have 2012 is that HIC-PICS code actually it's created and sometimes phased out year to year. This was adopted. This particular code was adopted in 2012, and actually I think after 2015, the phased out again and was used for the was adapted into CPT codes. So this is the data. Well, the previous slide is on the utilization of the BRCA testing. Right, so there is a difference in urban, metropolitan, non-metropolitan. And in this table actually is the well, the use of surgery procedures and also genetic counseling after genetic testing. Once someone is being tested, well, unfortunately, we do not know whether the person is being tested positive or not. And we try to see if there are any difference between urban and rural as well. And mastectomy, there are some difference, but not a lot. But MRI, there are some differences as well. Actually, it's not difference. Well, this actually is reasonable because MRI is much more accessibility of MRI is much higher in metropolitan area than in the rural area, right? Yeah, and mammography, surprisingly, also have some difference in 2009, but within a year, well, with a year after the testing of BRCA, it's actually not that significant. Yeah. So, which means that the accessibility of the mammography could be an issue, although they will be able to get an appointment of, within a years of time, but maybe not necessarily within 90 days. So there are some differences in getting access to mammography. And for genetic counseling, within 90 days, we can see that there's also differences as well from 5.3 to 3.8, and in 2011, it's also actually enlarged. Yeah, so there's a significant difference for the genetic counseling, and they probably genetic counselor, given that we have only about less than 6,000 certified genetic counselor. There's not much supply counseling, right? So they are most likely to be concentrated among the urban area. Well, we used another data set, which is American Hospital. Quickly generate a table of this. So there's a different. This means that providing genetic counseling, genetic testing, and counseling service within a hospital. And in metropolitan area, we have a, it's about 1/3 of them do provide, but it's even less than, I think probably 5%. 5% of them providing genetic counseling services, and the Pearson chi-square test is quite significant. So there is a difference in the hospitals providing these services as well. And we also are testing the for-profit and non-profit and the public one hospitals. And there's also differences as well. For-profit tends not to be providing genetic counseling, maybe because it's not profitable. Non-profit is more likely, and public actually is not as likely as the non-profit ones. Again, the chi-square is quite significant. Yeah. So I have not done much work on this, given the summertime. Really quickly. My next step probably will be like what Sai has been doing for the monkey skin, try to relate the provision of genetic testing at a hospital with a set of hospital level and also county level variables. Yeah, I think it is probably more close to Heejung's paper to explain the provision of genetic testing. Again, it's probably not surprising that urban area or metropolitan area are providing much more genetic testing and counseling, because this, just like specialists, they require a large population base, so that they do have to require a population that can support the service, right? Yeah. So I think that's probably not a surprising results. But what do we do about it? Well, over time, I think rural population might be migrating to urban population. It's continuing urbanization, right? But also, that's probably a long-term trend that we can expect. But over the short term or medium term, one way that we can address this is the genetics, using telemedicine to provide genetic counseling to rural population or hard to reach population. There are quite beautiful work on this, and I think there's there was a concern about the efficacy and also the confidentiality, patient satisfaction over telegenetics. But there were a number of randomized control trials, small ones, and they did find that the in-person genetic counseling and tele-counseling produce similar results, and similar level of patient satisfaction, and also the quality and other measures. Although there was some difference in take up of telegenetics, because in rural areas there could be a population that might be less likely to use IT technology, or maybe they do not have access to internet. So that's a concern that's been discussed. Well, so that's all my present. It's really a work that is still trying to figure out, and I love your comments, suggestions, and hope I can have time to write out, to finish the analysis and write out. The summer really flies. Well, thank you all for listening. Do you have questions?
No, I think it's very interesting, and I like the time frame or the different regulations. I wasn't aware of that, and it would be important to see how those regulations the impact on testing behaviors, and whether it is true the workers who get tested get discriminated in the workplace or not. So
Right, yeah. In I think before 2008, that was a concern. After 2008, that concern probably alleviated to some extent because of the law, right? The law gradually, I think, it took effect after 2008, but this was anticipated that this will be protected. Yeah, I do. Actually, I do have a short review, rapid review will be published soon in the Journal of China CDC Weekly, which we talked about the situation in China. China was actually also had the I think it's the non-discrimination for insurance. Yeah, for insurance. So insurance company cannot discriminate someone based on genetics. And then I think that's also passed after the GINA adoption of GINA. Yeah, but China, I don't think that they have a law in terms of employment protection yet. Yeah, although you probably know that the China's employment protection probably is not that good at this point. There are a lot of it. Yeah, this area actually is very interesting and growing interest. Growing interest. There are a lot of investments, and there are also new issues that are coming up. For example, I think there was a lot of ethical issues, social, ethical, legal, and the social implications of genetics. For example, one issue is that a father did a genetic testing and find out he had a certain genetic disease, but he did not tell his daughter. And his daughter then learned about the condition, but she already was pregnant, and she was very unhappy about her father's withholding the information. But this is it's going to be an interesting case of balancing between privacy and social impact. Right? That's a lot of the things that we need to think about. And of course, I think there are also things relates to economics as well, economic evaluation of the genomics, of the impact of the genetic testing, counseling, and other things. Great. Well, I think we do well, although we have a small audience. Thank you, Dia, for your loyalty and staying along with us.
thank you.
And also thank you for accepting this session proposal. I know Janani is not here, but thanks for accepting it. Janani is the person that submitted the proposal.
Yeah, this is a very interesting session. And thank you all for staying. This is the last session of the conference. So
yeah, and Dr. Tappa, she wanted to apologize to all of you because she's not feeling well, and so she couldn't join us today. So yeah.
Dr. Tappa and I, we both were agricultural economists. It's good to be virtually back to AAEA, and I hope that next year we can be there in person. Yeah.
Thank you all. I guess we can conclude the session. I mean, all the lectures are recorded, so the members could come back and watch your
Okay.
your talks. So and good luck with the two of you on your studies. They're very interesting, and I'm sure there will be more collaborations in the future.